CIMA has been specialising in pharmacovigilance for over 20 years and has headed up global pharmacovigilance and medical affairs before setting up SJ Solutions. SJ Solutions services span both consulting and contracting to provide solutions to drug safety, research and other affairs relating to the running of a business within the pharmaceuticals industry. CIMA has helped companies implementing the new EU legislation and is currently studying for her MSc in epidemiology. CIMA, over to you.
Thank you, everybody, and sorry about the delay. Just had some technical problems. Hopefully they won't have the same technical problems with Eudravigilance tomorrow, but I can't guarantee that. So welcome everyone. We're going to talk about signal detection and Eudravigilance, and this is a new area. It's something that's obviously where everyone seems to be quite interested in, looking at the numbers of the webinar. Now, I've tried to make this top line. I had allocated half an hour. It may take slightly longer, as in 5–10 minutes more, so just to make you aware of that, just in case you had other things that you needed to go to. But you can always get the recording. So I'm going to talk about the technical aspects, some of the technical aspects, as well as the process aspects. But there are a lot of documents that are aligned to this that would be useful to read should you need the further information. So, as I was saying, we've got the new Eudravigilance system, which is going live tomorrow, hopefully. It's been down since the 8th of November whilst they make these upgrades. And the reason for the upgrades is because of the legislation that was put into place into 2012, where Eudravigilance was meant to be accessible to MAHs so we could comply with our obligations. Also monitor Eudravigilance as well. That's where the signal detection comes in, and the management aspect, to have access to the database and to ensure continuous monitoring of data on a risk-based frequency. Now, we need to be able to detect new signals through Eudravigilance, validate them, and then inform the EMA and national competent authorities, and that's really where this has all come from. So, just to kind of go back and just look at what our responsibilities are as an MAH. So we need to continuously monitor the safety profile of our products. We need to ensure that all sources are considered, of which Eudravigilance would be considered one of those. We need to inform the authorities of new information and emerging safety issues, and also ensure product information is up to date. And that's all part of the signal management process leading through to these different outcomes. Now, what is new is that signals that are identified through Eudravigilance now have to be managed according to the updated GBP Module 9, and 9C particularly is where they talk about this. Now, process-wise, I mean, in previous webinars we've talked about this, the detection, validation, confirmation aspects, analysis, prioritization, assessment, and recommendation for action. I think through this, though, the confirmation and the analysis are two different steps now when you're looking at signals that have been identified within Eudravigilance. These have been added in, and we'll talk about that and exactly what that means. So to start with detection, and there's a lot on detection because obviously we're now looking at how we use Eudravigilance for the signal detection aspect, looking at the alerts. I mean, we'll look at it as well from a management aspect, but really a lot of it is focused on the detection. And definition is looking for or identifying signals using data from any source. And as I said, Eudravigilance is now the new source. Now, eventually, what will be in place is that MAHs will have to monitor or review Eudravigilance, and this will have to be on a risk-based approach where the MAH will determine the periodicity. However, it needs to be at a minimum of every 6 months, or more frequently if you have a product that is under additional monitoring, except where you have a product that's under additional monitoring because they have a pass ongoing, in which case you could actually go to the 6 monthly if it's appropriate and justifiable. What's important here is that you need to justify whatever periodicity you do look for your product or implement for your product. Now, there's a phased implementation ongoing, so Eudravigilance is going to be updated, ready, hopefully, from tomorrow. However, for monitoring and looking at the signal management aspect of things, there is a pilot that's going to be put into place, and this will give us time really to familiarise ourselves with the data that's available and the tools, which I'll come on to. So the scope of this pilot are any products that are on the additional monitoring list as of tomorrow, and that's available on the EMA website. And the monitoring starts from the 22nd of February 2018. So you've got 3 months basically to get yourself set, and then for those products on the additional monitoring list, you need to start looking at Eudravigilance from the 22nd of February 2018 from the signal detection perspective. After a year, there'll be a report back to the European Commission and then a decision on the next phase of the implementation. And it's quite good that we're doing this in this way because it gives an idea, it gives us a chance really to feed back and say if things aren't working out and for things to hopefully change should there be issues. Now, if you do have a product that's on the additional monitoring list as of tomorrow, you'll need to think now about determining the frequency for monitoring Eudravigilance for your product. And if you have a few products, it may be better to stagger the analysis so that you have time really to perform the proper analysis and detection, etc., rather than having everything fall on, say, the 22nd of February or the 30th of February. You know, it's probably best to stagger it. Now, within scope are all of the drug event combinations, so anything that's highlighted, but as of the 22nd of February 2018. So you don't look, it's only prospectively from the 22nd of February. Now, for other products, they're not part of the pilot. You don't need to, you're not meant to be continuously monitoring Eudravigilance to inform the EMA of validated signals, but because you will have access, there is an expectation that you will look at this as an additional source for signal management overall and consider it in your signal management process. And you are expected to analyze data from Eudravigilance, certainly for evaluation of your signals. And if you are refuting a signal, it would be also expected that you would look at Eudravigilance to ensure that you've considered all of the data as appropriate. So looking at access now to EV Web, so there is a guideline that's been produced. It's quite a hefty one, but it gives you all the details with regards to access and what that means. And you've got 3 levels basically. Level 1 is the publicly available fields. Level 2 is where you have ICSRs or cases that have been sent in by another organization but associated with your products. And you have 2A and 2B. So 2A is where you have a certain number of fields, and 2B is an extended information or data that's available to you and will include the narrative. And 2B is important because with the narrative then you're able to actually do your signal validation, do your signal detection and assessment and valuation as well of signals moving forward. It's important to have that level of detail so you can look at the cases that have come in, not necessarily just the ones that you've sent, but that are related to the active as a whole. And then level 3 are cases that you would have sent in and also from the literature monitoring by the EMA, and you have complete access to that, of course. Now, to grant level 2 access, I'm sure many of you have already done this, but the QPPV grants level 2B access to users. There isn't a limit to the numbers that can have this access, but you do need to sign a confidentiality electronically to confirm that that access to narratives, etc., are required to meet your PV obligations, and that, of course, will include signal management. And this can be done via the Eudravigilance system. Now, whoever does have access, though, to Eudravigilance needs to familiarise themselves with the guidance and the training, and also needs to make sure that there is documented training according to the company procedures to show that that has occurred. So you know what you're looking at, you know how to retrieve things, and basically you're able to perform the activities that you need to through looking at Eudravigilance. So I wanted to touch now on EVDAS. So EVDAS is the Eudravigilance Data Analysis System, and it's basically taking information from Eudravigilance and displaying it in certain ways that will enable you to perform your signal detection and analysis. Now here, registration is for authorised people, and the QPPV or deputy can do that, but it is limited to 5 users at the headquarter level. So it's not as with the 2B access, which was much broader. This is, really is limited as to who can have access here. There are 2 different profiles. You have the administrator and then the scientific. Now, you're able to generate your electronic reaction monitoring report, which I'll come onto in line listings, through the administrator and scientific, but the scientific profile will have access to the cases and the narratives and be able to do more of that deeper dive. So if we look at EVDAS, this is based on active substance level, and again, when I show that, you'll see what I mean. There's one case where the active is suspect or interacting, so the data for that active is presented where it's considered a suspect or interacting product. And the cases that are included are spontaneous and studies, and others are not available to sender. And I think it's important to understand exactly what is included in the system so that you know exactly what you're looking at. It's similar to when you have data mining outputs from your own say database in-house, and understanding exactly what data is pulled out and how it's presented so that you can make the right assessments overall. So if we look at EVDAS, this was just a diagram that was presented. You can see that you have EVWeb cases coming in through the gateway into the database, and then EVDAS is where that data is taken and then presented in a certain way so that you are able to look at the data for data mining, for signal detection and assessment and evaluation if needed. So when you go into EVDAS, you'll see different tabs at the top. One of the tabs is the Active Substance Group tab, and this gives you an overview of what's included under an active substance. We all know that, from a signal detection perspective or signal evaluation, the active substance really is what we're interested in and looking at. And the active substance at the high level includes different salts, perhaps, of the same product. So it could be, for example, amlodipine would be the active substance high level, and that would include amlodipine, benzoate, maleate, mesylate, so all of the different salts, but amlodipine is the active substance high level. But you can go into that tab and have a look and see what's included. So again, you can understand the data that you're looking at. It helps because you can aggregate the data, as I was saying, and you can query at high level at the active substance itself, medicinal product level, or MAH, depending on what you're using EVDAS for. Oh, let me go to the next slide. Now moving on to the electronic reaction monitoring report. Now this is very similar to the, as I was saying, the signal kind of the alerts that are generating or the data mining outputs that you get, where you look through and you look for disproportionality analysis and look for the types of events, etc., that you want to look at in more detail. So it's really a tool to help with that signal detection aspect, and it's a report. It presents data in an aggregated format, so you can see if there is anything that is of a specific concern, and it's stratified by different parameters. And as with any of these kind of reports, what it's doing is highlighting total cases cumulatively and new cases depending on which reference period you've chosen. So you can see the cases from the reference period compared to what's been seen cumulatively, and then decide if there is anything that you want to look into in a more detailed way. Now you run a report, and there are various prompts to help you run the report. It gives you different data sets. The things that you need to think about are the output type. What type of report do you want? There are 2 types, a fixed or an ad hoc. The active substance at high level, again, that's where you understand then what's included under the active substance on the other tab. The reference period, so what period are you interested in to compare to cumulative data, and then what are you interested in from the Meddra hierarchy? Are you interested in a specific PT, HLT, HLGT, or SOC? And this is just an example. I don't know if you can see that too well, but you can see that here you've got ad hoc or fixed, then you've got your active substance. If it's an ad hoc, you can choose your reference period, and that's here, and then you can decide what you want to look at from the Meddra perspective. And this is just part of the spreadsheet, or part of the output, which just shows you the SOC, HLD, GTs, HLTs, even an SMQ basis, and the different PTs. So here they've chosen the SOC, and you've got different PTs that have come out here. So looking at the different types of reports, so you have your fixed and your ad hoc. The fixed are generated on the first day of every month, and it won't change until the next month. And the reference period is 6 months, basically. So 6 months, new data, cumulative, compared to cumulative data. Once, though, you generate that report, you won't be able to retrieve previous period ERMR. So just to remember that, so it overwrites what you've retrieved previously, but you can select more than one substance in the same report. The ad hoc report, though, is restricted to 3 months and 2 weeks, so 105 days, basically, and it can only do one substance at a time, but it is updated every day and is considered the most up-to-date. So, again, depending on what you're looking at, if you're doing your standard 6-monthly signal detection, the fix may be appropriate, but if you're looking at something specifically, you may want to do the ad hoc to be able to manage some of those data elements. So looking at the reference period now, so within the reference period, what you're looking at are new cases. So these would be cases that were received for the first time in Eudravigilance, any follow-ups. And if you've had a duplicate report, when they've deduplicated it, as they say, then and you end up with one master report or master case, this will show up as a new case. And again, it's important to understand what will show up as new cases, because that can have an impact then on what is shown from a disproportionality perspective, or where you suddenly see maybe, you know, a couple of cases of a significant event and you think, where did that come from? It could be that that's what's happened. You can also look at changes. So, of course, you've got the new cases, but you can see increased number of cases and increased fatal cases as well. Again, to give an idea if there's a trend in any way with regards to things that have been reported previously, but you're seeing an increasing number now. There's also highlighting of designated medical events, and these are events that are kind of picked out because they may occur or tend to occur in a high proportion of cases in a causal association. So, and then you've got your important medical event as well, and your signal of disproportionality reaction, which I'll come on to in a minute, and IME, important medical event, fatal reports as well. So all towards highlighting areas that you may want to look at. So your designated medical events, your important medical event where you've got a signal of disproportionality, and then your important medical event with a fatal outcome, because the fatal outcome may indicate that there is an issue here from a public health or individual patient perspective that needs to be looked at. So just to the right slide here. See myself, and this is just, again, you won't be able to see it in great detail, but it shows you what the report looks like, and you can't see the tabs at the top, but you've got your SOC here, you've got your active substance, your SOC, and across here you've got a whole load of different data fields, some of which we'll talk about in more detail, but you've got whether it's a DME or an IME, so, you know, important medical event or designated medical event. You've got your disproportionality here as well to help, again, guide you as to what you should be looking at. And then there are various other fields which we'll talk about as well. This is just to show you that if you did want to just look at perhaps those where you'd had an increase of cases in the reference period, you can then select that through the filter here, increased fatal and new cases. And this is just to give you an idea. You've got a PT here, you've got your new cases, total 4, new fatal, total fatal. So, you know, it may be that this is something you might look at, depending on what the cumulative time period is and what the reference time period is as well. These are snapshots of that bigger spreadsheet. I say spreadsheet, it's a report, I should say. So looking at other areas, so as I was saying, there are other columns that you can see, and these are so that you can look at other things that might be important, such as medication errors, where you've got positive rechallenge as well. Literature reports are pulled out separately, and you can also look at route of administration and indication for use, but it's only the 3 most common routes of administration or 3 most common indications that are available, and your indications are grouped per HLGT. It's important to remember, though, that as we know from when we interrogate our own safety database, that you may not have a lot, some information may be missing, in which case it may not be absolutely representative of what's happening in the real world. So this is just to show you the medication error bit here, there, and literature here. So moving on now to the signals of disproportionality reporting, and here what's important is that these are shown in the report, and they take into account various thresholds or various parts to make up what would be considered a signal of disproportionality reporting. So here you can see the different components. So the first is the ROR, which is a disproportionality statistic. So are we seeing this event occurring with this drug more than we would expect to see it? That's what that is about, and it's the reporting odds ratio that's used. And there is a guideline, the screening for adverse reactions in Eudravigilance, which goes into a lot of detail as to why ROR was chosen over some of the other disproportionality ratios, such as your PRR. And it is, if you're interested in those aspects, it is a good document to read because it gives you, the false positive rates, the false negative rates, benefits, the issues associated with the different disproportionality ratios and why that one was chosen. Then, importantly, need to consider number of cases as well, because if you use the ROR on its own, then there would be many false positives because it's really showing you what's been reported on. It's really a depiction of what's been reported on the database, whereas the cases do add something further and really will help to increase the positive predictive value overall, because otherwise you would have too many false positives that you would have to look through. And this really does increase overall the reliability of what's shown up and the alerts that you see. Within Eudravigilance, the event also has to be on the IME list. So it has to, for the total, without looking at a special population, you have to have the lower bound 95 confidence interval for the ROO, the reporting odds ratio, to be greater than 1. So there has to be something statistically that's showing this is seen more than you would expect with that drug. For the number of cases, you have to also have 3 cases if your product's under additional monitoring, and that's to increase the reliability overall of the alert. 5 cases if it's under routine monitoring, and also has to be on the IME list. So anything that meets this criteria will show up as a signal of disproportionality reporting on the report. When you look at the special populations for pediatrics and geriatrics, we add in this relative reporting odds ratio, and that's where you take the reporting odds ratio in the total population, in the special population compared to the total population. So what you're then saying is that actually we're seeing this disproportionately in the special population, and therefore needs to be looked at specifically for that special population. And you can see the case numbers are slightly different, 2 with additional monitoring for peds, 3 for routine monitoring for peds, but similar from the elderly perspective. They don't include litigation cases within this analysis, Again, important to know, they've shown, again, if you read the guideline, it quite clearly shows that it doesn't add anything by adding in the litigation cases. So moving on now. So looking at detection overall, so there are other aspects as well, the clinical method. So we said the designated medical events. This is shown within EVDAS. So it helps you to identify perhaps single cases, a couple of cases where perhaps there's no signal, but it's an important area to look at. IME fatal cases, and then targeted medical events for pediatrics as well. And then you have your signal of disproportionate reporting. May need to even look at that though, even if it's not showing that it is statistically significant. But I think what is important and what comes through all the way through is that clinical and scientific judgment is extremely important when looking at these data. The other outputs you get are your line listings. You get your cases at level 1, and these have very few fields, as you can see, compared to level 2B, 55 compared to 230. And these are similar to your old kind of COMS2 line listings that you used to get. You do get the worldwide case ID, so you can retrieve the narrative then. And you can retrieve your line listings from your RMR, from the report, or you can retrieve cases from your line listing as well. And this is just to show you that you can see this is one of the reports, and you can click on that. It will take you to the line listing. Within the line listing, you can click on the ICSR form and get the case form. And ICSRs obviously are available. There'll be static sections and dynamic ones. So statics will always stay the same. Dynamic will depend on where the data has been entered, and they will be retrieved within the as an R3 basically document. So I wanted to touch on validation now, and this is really about, so there's a lot of information again in GVP Module 9 with regards to validation. To clarify it, I know people found it quite difficult to understand the validation step, but here what you're doing is evaluating the initial data and say whether you've got enough evidence for either a new causal association or a new aspect of a known association. And whether you need further analysis or not, or whether no, you don't, and it's considered a non-valid signal based on the data that you've reviewed. It's a quicker process than a formal assessment and less extensive, but you do need to look at Eudravigilance data to perform the validation step. And importantly, you should also ensure that the signal is new, i.e. not being seen by you before, or even by other products, basically, where you're not the MAH, but it could be within the label, so you should actually check other products as well. Once you've done your validation, and your validation step, if your case is, if your signal is valid, then this will be considered your day 0, where you then have your internal processes to manage your signal assessment or non-valid signal. But if you move on to signal assessment, this is more extensive, more data to look at, and then you decide on regulatory action. If you have, I've said this before, if you had a non-Eudravigilance signal, then you should look at Eudravigilance for signal assessment overall, and things to look at are literature, your safety database, clinical trials. Now, when you perform your MAH assessment, this is the day 0 for your Eudravigilance signal notification or next step, depending on what is going to be done. So if we look at outcomes, outcomes can be refuted, no further action, new or updated risk of variation, or further assessment is required, and that could either be through the PSUR, if this is within 6 months of your day 0, or a notification if it isn't. And this is only for signals that have been identified through Eudravigilance. So looking at your signal notification, so this is validated signals identified through Eudravigilance monitoring, not if you have an emerging safety issue, not if you have submitted a variation, not if you have a PSUR, that is due within 6 months and your product is on the EU reference date list, not if it's detected outside of Eudravigilance or if it's refuted or non-validated. So as long as it doesn't meet any of those criteria, you need to then inform the EMA of your signal, and that needs to be within 30 days of your assessment, of completing your assessment that day 0, and this is the email to send to. We're awaiting the template. So to try and make it a little bit easier, there is a flow here that can hopefully help. So you have your validation aspect, non-validated signal, don't do anything. Emerging safety issue, 3 days, 3 working days for notification. Validated signal, assessment, refuted signal, don't do anything. Further analysis required. If you have a PSUR within 6 months on the EURD list, you submit it in the PSUR. If you don't, you have a standalone signal notification within 30 days. If it's a new or changed risk, you have a variation. 3 months for important risks, 6 months for others. So when you do get your signal the signal notification is received within the EMA, it's entered onto EPIT within 30 days, allocated to a PRAC rapporteur or lead MS signal, depending on the type of approval, and then they will decide whether or not further analysis and prioritization is required, and that's within 30 days of receiving that signal. So if you do need prioritization and analysis, then it will be added on to the PRAC agenda. QPPVs will be sent a list of all of those notified signals, and any signals that are confirmed 10 days prior to the PRAC meeting are included in the agenda. But if it's on the agenda, it does not mean that there is an implied causal relationship. So looking at confirmation and reasons for non-confirmation, it could be that it's already been handled through a different procedure, such as the PSUR. Could be that it's already reflected within your label or even other products' label as well. Remember, I said you need to check that to make sure that it is a new signal. May have been already reviewed and considered that the new data is not substantial, or the available data doesn't warrant further analysis. And when there is non-confirmation, that reason is shared with the MAH so that they are aware of what has occurred. Now, PRAC will then look at signal prioritization. This could extend to other products in the class. They may say further assessment needed and will appoint a rapporteur. And there's a time frame then for that assessment, and usually they will request additional data from the marketing authorization holder, and default is usually 2 months for that additional data. They produce they publish their timetables for signal assessment on the website, but they could also recommend that the assessment is performed in another procedure, such as a PSUR. Maybe it's slightly out, but they say, no, we want you to consider this within the PSUR, in which case the PSUR timelines will overtake the 2-month timeline here. Sorry, let me get to the right slide. Right, so outcome and recommendations. So we had the outcomes from a signal assessment from a MAH perspective, but at PRAC level, I mean, we've seen some of these already. So additional data, got to update the PI, update or submit your risk management plan, put in additional risk minimization measures, may need a post-authorization safety study, or it could go through to a referral procedure, and that could be invoked, such as Article 31. Additional data may be needed at the agency level rather than the MAH level even. Could even go out to scientific groups to get more data, more information before they make their decision. Or it could be that actually routine pharmacovigilance is appropriate, and that is the recommendation. Wanted to touch on emerging safety issue, because that now is part of Module 9. Has moved from Module 6. And this is really a safety issue that requires urgent potential major impact on the risk-benefit balance of the medicinal product, or in relation to patients or public health. So you need something that needs prompt regulatory action and communication, and this is the email address that should be used for notification there, and that's 3 working days. what you need to do is describe the safety issue, where that's come from, what actions you planned or have taken, and timelines with the relevant documentation. If, though, as part of that, you're looking to suspend your product or withdraw it or request to withdraw due to this, then this information should be sent to this email address concurrently along with the emerging safety issue. Now, if you have a quality defect or issues arising from quality defects or falsified products that could affect your benefit risk of your medicinal product in a significant way and leading to abnormal restrictions supplied, this is not considered an emerging safety issue and should be sent to this email address here. So, looking at requirements now from the MAH perspective, it's important that you have a robust signal management system in place, that this is documented and your record management is in place appropriately too. I would assume that's available as of now, and that you have the appropriately qualified staff to perform the signal detection activities and signal management activities. You need to have evidence that Eudravigilance data has been reviewed, including the reference period of data extract and who has performed that and when that was conducted. You need to document your statistical approaches, including your threshold, so similarly to what I've shown already, where you have your reporting odds ratio as well as your number of cases, and that should be defined up front as to what you're going to use as your threshold for picking out appropriate alerts and signals. You need to have written procedures for monitoring frequency and justify what your frequency should be. If your frequency for Eudravigilance differs to what you have for other sources, you need to state that and state why that's appropriate. And for your DECs for further review, so drug event combinations, so alert signals, whatever you want, things that need further review, you need to have something that shows that scientific judgment should be used and guidance as well to aid selection as to what should be picked out and reviewed and looked at, taking into account the clinical aspects as well that we talked about, so the fatal IMEs, your designated medical events, things that really should be looked at if they occur with your product. From an inspection perspective, you need to ensure that timeliness of signal notifications are documented, measured. That's something that should be looked at on a regular basis. You've got your 30 days for those signals that that need to be notified to the EMA. You need to ensure that you've got a process to check whether the risk is already known to authorities or not. So again, either that it's been picked up previously or is in the PI of other products as well. Remember that Eudravigilance is one source of many, so your signal processes, although, yes, this is about Eudravigilance, don't forget the other sources that are available and need to ensure that is covered in your processes and procedures. And you should consider product and population-specific issues and the various guidelines that are available for those as well, such as the vaccines and the biologics. So in summary, Eudravigilance access to MAHs is from 22nd of November, tomorrow. Pilot will be from 22nd of February for 1 year, and that's only for additional monitoring products. That's only for products that are under the additional monitoring scheme, and that's from as of the 22nd of November. So any additional monitoring products that are on that as of 22nd November are in the pilot. You need to look at your frequency of signal detection in Eudravigilance for the pilot, but also consider it for other products as well. EVIDAS is available as your system for signal management, the reports that can be generated to look at and review. You have your electronic RMRs, your line listings, and your cases will assist you in your signal detection to pick out what's been seen on Eudravigilance, and then your management aspect to look further and do a deeper dive into the data. Confirmation needs to be in 30 days, but only for validated signals identified in Eudravigilance that don't meet the other criteria that we talked about. And you need to consider Eudravigilance as a data source for all products, and Eudravigilance should be reviewed as part of the signal assessment as well. So I think that's the last slide. I know it's a very quick trip through a very big topic, but hopefully it gives you an overview and some things to look at. Are there any questions? So according to the marketing authorization holders own signal, take into account general signals, for example, clinical trials, or it should be interpreted, should parallel monitor EVDAS. So just so I've understood that correctly, so you have your own database and you would monitor, you should really monitor your own database unless there's a reason that you couldn't for data mining, basically data mining, use a data mining tool on top of that if that's appropriate. And you should also look at Eudravigilance if you have products within the EU. But the requirement is only for the pilot, which is those products that are under additional monitoring as of February. Although you would be expected to look at Eudravigilance for other signals that you're looking at. Does that answer your question? Yep, okay. Are there any other questions? I'm sure there are quite a few. No, okay. I mean, the guidelines, oh, sorry, someone's typing. Nope, okay. The guidelines are useful. I mean, if you're I'm sure a lot of you would have read GVP Module 9 from before anyway, so it is useful to read that. I think the adverse reaction, monitoring Eudravigilance for adverse reactions is quite helpful because it gives you the underlying assumptions and how to pick out things to look at further from a signal perspective. But I think, so Stefan said, if I understood well, only IME and DME should be assessed. What it's doing is it's highlighting your IME fatal events and your designated medical events so that you can look at them. It's not that those should only be assessed, you know, but they are more likely to be causally associated or to have a significant impact from a public health or individual patient perspective, and that is why you would focus on those. But you should look at the data as a whole to see if there's anything that's significant that's coming out. So EVDAS access will be given to everyone, well, every MAH that has a product within the EU, but you have to request access through your QPPV, and it's limited to 5 users. Okay. I know I've gone over. I'm sorry about that. But if you do have questions, please do email me, or, you know, always open and can certainly get back to you. Okay. I think that's it. Yes, we can. It will be available. The presentation will be available afterwards through the recording will certainly be available as well. Okay, thank you everybody. Enjoy the rest of the day.